Hi everyone, welcome back to the channel. Today we're going to break down the essentials of urinalysis, a common non-invasive test that analyzes the content and appearance of urine to help diagnose and monitor a wide range of medical conditions. The indications for urinalysis include fever of unknown origin, diabetes mellitus, suspected renal disease, drug screening, suspected hormonal abnormalities, electrolyte disturbances, pregnancy tests, and urological malignancies. Let's begin with the gross examination of the urine, which includes color and turbidity. Normal urine is pale yellow. Red urine may indicate hematuria, which means presence of blood in urine. Rifampin, an antibiotic commonly used to treat tuberculosis. Porphyria, a rare metabolic disorder that affects heme synthesis. And beetroot consumption, which can temporarily color the urine red in some people. And brown urine may signal dehydration, which concentrates the urine, or it may signal alkaptonuria, a rare metabolic condition where homogenistic acid accumulates and darkens the urine upon standing. Normal urine is clear. Common causes of cloudy urine include urinary tract infections, crystals like calcium oxalate or uric acid, which can precipitate, chyleria, which is the presence of lymph in urine, most commonly due to filarial infection, a parasitic disease transmitted by mosquitoes that invades the lymphatic system. Proteinuria, which means high amount of protein in the urine, and dehydration. Let's move on to the urine dipstick test, also known as the chemical analysis of urine. It's a quick and easy screening tool that uses a plastic strip coated with reagent pads. When dipped into fresh urine, each pad changes color depending on what it detects. It gives us a lot of information in just 1 to 2 minutes. If the strip tests positive for blood, it usually points to hematuria, or presence of blood in urine. This can happen due to renal diseases such as glomerulonephritis or tubulointerstitial nephritis. It may also be caused by urinary tract stones, infections, tumors, or trauma somewhere along the urinary tract. Since the strip reacts to heme, not just red blood cells, it can also turn positive with hemoglobin from hemolysis or myoglobin from muscle breakdown like rhabdomyolysis. And don't forget to ask about the patient's menstrual cycle, since contamination from menstrual blood is a common cause of false positives. Next, the urine pH. Urine is usually slightly acidic with a normal range between 4.5 and 8. If the urine pH is below 4.5, it often reflects acidemia in conditions like diabetic ketoacidosis, diarrhea-induced metabolic acidosis, and lactic acidosis, where the kidneys excrete more hydrogen ions. It also happens with a high-protein diet because amino acid metabolism produces acid. If the urine pH is greater than 8, it often reflects alkalemia, like after prolonged vomiting or loss of gastric acid. It's also seen in type 1 renal tubular acidosis, where the distal tubule fails to excrete hydrogen ions, making the urine inappropriately alkaline despite systemic acidosis. Another key cause is urinary tract infection with urease-producing bacteria, like Proteus or Klebsiella. These bacteria break down urea into ammonia, which raises the pH. Next, urine-specific gravity or SG. This tells us how concentrated the urine is, basically how many solutes are dissolved in it. The normal range is roughly 1.005 to 1.03. When the urine-specific gravity is high, it means that the urine is more concentrated. This can happen in dehydration, where the body is trying to hold onto water, so the kidneys produce less but more concentrated urine. It can also happen in glucosuria, like in uncontrolled diabetes. When glucose spills into urine, it pulls water with it, raising the specific gravity. Another cause is SIADH, or syndrome of inappropriate antidiuretic hormone secretion, where excess ADH causes the kidneys to reabsorb too much water, concentrating the remaining urine. And in conditions like congestive heart failure or cirrhosis, poor perfusion to the kidneys activates the RAAS and ADH systems, again leading to water retention and a higher specific gravity. On the other hand, when the specific gravity is low, the urine is very dilute. One cause is diabetes insipidus, where either there's no ADH or the kidneys don't respond to it, so water is lost in large amounts and the urine stays dilute. Another cause is renal failure, especially in late-stage chronic kidney disease, where damaged nephrons lose the ability to concentrate urine. Next up is protein in the urine. Normally, urine should contain little to no protein because healthy kidneys prevent large molecules like albumin from passing through the glomerulus. So when the dipstick shows positive for protein, we call that proteinuria. And it usually means something's wrong with the kidneys. One major cause is glomerular disorders, like nephrotic syndrome or glomerulonephritis, where the glomerular filter is damaged and allows protein to leak through. Another cause is tubulointerstitial diseases, where the tubules are damaged and can't reabsorb the small proteins that are normally filtered. Proteinuria can also be temporary, like during fever, strenuous exercise, or emotional stress. In these cases, it often goes away on its own. There's also the possibility of a false positive, especially if the urine is very dilute. Now let's look at leukocyte esterase. This test detects an enzyme release from lyse neutrophils. So when it's positive, it suggests the presence of white blood cells in the urine, or what we call pyuria. It's most commonly seen in urinary tract infections with sensitivity of up to 80%. But there are also some false positives to watch out for. Things like certain antibiotics, proteinuria, glucosuria, and even vitamin C can interfere with the reaction and give misleading results. Another urine dipstick parameter that detects urinary tract infection is nitrites. This test checks whether bacteria in the urine are converting nitrates to nitrites, which is something that only certain bacteria can do. So if it's positive, it strongly suggests a UTI caused by gram-negative bacteria. The most common ones include E. coli, Klebsiella, Proteus, Enterobacter, and Citrobacter. But it's important to remember that not all bacteria produce nitrites. Enterococcus and Pseudomonas, for example, are common UTI pathogens but won't give a positive nitrite result. So a negative nitrite doesn't rule out infection, especially in hospitalized or catheterized patients. Next up is glucose in the urine. Normally, the kidneys reabsorb all the filtered glucose, so urine glucose should be negative. Presence of glucose in the urine is known as glucosuria, which is commonly caused by hyperglycemia or high blood glucose. This happens when the blood glucose levels exceed the renal threshold, usually around 180 milligrams per deciliter. At that point, the kidney can't reabsorb all the glucose, so it spills into the urine. Some common causes include diabetes mellitus, especially when it's poorly controlled, Cushing's syndrome, where excess cortisol increases glucose production, hyperthyroidism, which speeds up metabolism, pregnancy, which may cause mild glucosuria due to increased kidney filtration, and steroids, which may also increase glucose levels. But not all glucosuria is caused by high blood sugar. We also see euglycemic glucosuria, where blood glucose is normal but glucose still shows up in urine. One example is SGLT2 inhibitors, a class of anti-diabetic drugs that purposely block glucose reabsorption in the kidney, so glucose is excreted even if the blood levels aren't that high. Another cause is Fanconi syndrome, where the proximal tubules are damaged and can't reabsorb glucose properly, along with other solutes like phosphate and bicarbonate. Now let's talk about ketones in the urine. Ketones are chemicals your body produces when it breaks down fat for energy, usually because it doesn't have enough available glucose. When ketones show up in the urine, we call that ketonuria. The most important causes involve ketoacidosis, which includes diabetic ketoacidosis or DKA, where a lack of insulin leads to uncontrolled fat breakdown and massive ketone production. Alcoholic ketoacidosis, which happens in chronic alcohol use combined with poor nutrition. And starvation ketosis, which can occur after prolonged fasting or strict dieting. Pregnancy can also cause mild ketonuria, especially if the person isn't eating enough due to nausea or vomiting. Certain drugs like pyridine or chlorpromazine can cause the strip to incorrectly read as positive. Next up, bilirubin and urobilinogen. To understand the test, we first need to understand the metabolism of bilirubin. Heme from old red blood cells breaks down into unconjugated bilirubin, which is not water-soluble. Unconjugated bilirubin binds to albumin and travels to the liver, where it is converted to conjugated bilirubin, making it water-soluble. Conjugated bilirubin is then excreted into bile and eventually enters the intestine, where it is converted to urobilinogen by bacteria. Some of that is reabsorbed into the bloodstream and excreted in urine, while the rest is converted to stercobilin and gives stool its brown color. Normal urine contains no bilirubin, because circulating bilirubin is primarily unconjugated and water-insoluble. Conjugated bilirubin, although water-soluble, should not be present in urine under normal conditions since it is efficiently excreted into bile. Urobilinogen may be present but normally at less than 1.5 milligrams per deciliter. Now let's see how this relates to different types of hyperbilirubinemia or presence of bilirubin in blood. In prehepatic causes like hemolysis, there's excessive breakdown of red blood cells. This produces a ton of unconjugated bilirubin, which can be excreted in urine. But because more bilirubin enters the gut, more urobilinogen gets produced, so you might see increased urobilinogen in the urine, but no bilirubin. In hepatic causes like hepatitis or cirrhosis, the liver can process or excrete bilirubin properly, so both conjugated and unconjugated bilirubin build up in the blood. You may see bilirubin in the urine because conjugated bilirubin is water-soluble, and urobilinogen may be normal or elevated, depending on how much bilirubin actually reaches the gut. Finally, in post-hepatic causes like biliary obstruction, conjugated bilirubin can't get into the intestine at all. So you'll see elevated bilirubin in urine, but urobilinogen will be absent or very low, because there's no bilirubin in the gut to convert. Now let's move on to urine microscopy, also known as the urine sediment exam. After we dip the urine, we spin it down in a centrifuge and look at the solid part, called the sediment, under the microscope. This helps us directly visualize cells, casts, crystals, and microorganisms that can't be picked up by the dipstick. Let's start with cells. If we see red blood cells in the sediment, that confirms hematuria. As we mentioned earlier, this could come from glomerular disease, stones, UTIs, tumors, or trauma. Microscopy also lets us assess the shape of the red blood cells. Dysmorphic red blood cells suggest a glomerular source, while normal-looking ones point to something lower down the urinary tract. Next, white blood cells or WBCs. White blood cells in the urine means pyuria, and that's most commonly due to a urinary tract infection. But it can also show up in renal stones, where the lining gets irritated, or in acute interstitial nephritis, a hypersensitivity reaction often triggered by medications. Then we have squamous epithelial cells. These are flat irregular cells from the skin or outer urethra. If you see more than 5 per high-power field, it usually means the sample is contaminated, and the results should be interpreted with caution. Next, let's talk about urinary casts. These are cylindrical structures formed in renal tubules. They trap whatever cells or debris that are present in the tubule at the time, which help us localize disease to the kidney itself. Let's go through the common types. First, hyaline cast. This is the simplest type, just pure protein, no cells inside. It's considered non-specific and can be seen in dehydration, after exercise, in patients on diuretic, or in chronic kidney disease. On its own, it doesn't necessarily indicate pathology. Next, the granular cast. This one has a grainy texture and usually forms from the breakdown of cellular debris. You can see it in more serious conditions like glomerulonephritis, pyelonephritis, or even malignancy. It's more suggestive of active renal disease. Then there's the muddy brown cast, which is basically a subtype of granular cast, but with a dark, dirty appearance. It's considered highly specific for acute tubular necrosis, or ATN, which happens when the cells lining the renal tubules are injured and start dying off. Now onto the white blood cell casts. These indicate that white blood cells are coming from within the kidney, not just the bladder. They're classic for acute pyelonephritis, but also show up in acute interstitial nephritis, especially drug-induced. Red blood cell casts are very important. They indicate that red blood cells are leaking through the glomerulus and getting trapped into tubules, so this finding is specific for glomerulonephritis. It can also be seen in severe hypertensive emergencies, causing glomerular damage. Finally, the fatty cast. This one contains lipid droplets and looks like it has Maltese crosses under polarized light. It's most often seen in nephrotic syndrome, where heavy proteinuria leads to lipid-rich tubular filtrate. Now let's talk about urinary crystals. These are solid particles that form when certain substances precipitate out of urine. Let's go through the most common types. First up, calcium oxalate crystals. These are the most common, found in about 75% of kidney stones. They appear as envelopes or dumbbells under the microscope, and they can form in any pH, whether acidic or alkaline. They're associated with hypercalcemia, hyperoxaluria, and conditions like inflammatory bowel disease or vitamin C overuse, which increases oxalate levels. Next is uric acid crystals, found in about 10% of stones. They have a rhomboid or needle-like shape and form an acidic urine. Common causes include gout, tumor lysis syndrome, or any condition with high purine turnover. Then we have struvite crystals, also known as magnesium ammonium phosphate. They make up around 5 to 10% of stones and appear as coffin lid-shaped crystals. They form in alkaline urine, usually in the setting of UTIs caused by urease-producing bacteria, like Proteus or Klebsiella. Calcium phosphate crystals are less common, around less than 5%. They look like rosettes or prism-shaped plates, and they form in alkaline urine. They're associated with type 1 renal tubular acidosis and hyperparathyroidism. Lastly, we have cystine crystals, which are rare but very distinctive. They appear as hexagonal plates, and they form in acidic urine. They're seen in people with cystinuria, a genetic disorder that affects amino acid transport in the kidneys. Finally, let's talk about microbes in the urine. When we see bacteria under the microscope or on culture, we call that bacteriuria. But it's important to know how we define it, because it depends on how the urine was collected. For a clean catch midstream sample, significant bacteriuria is defined as 10 to the 5th power colony-forming units per milliliter, or CFU per milliliter. But if the sample is taken through a catheter, the threshold is much lower. Just greater than 100 CFU per milliliter is enough to suggest infection. And for a suprapubic aspiration, where the sample is taken directly from the bladder with a needle, any bacterial growth at all is considered abnormal, because it should be a sterile environment. Seeing microorganisms along with white blood cells, nitrites, or glucosylester helps you confirm whether you're truly dealing with a UTI. In addition to bacteria, sometimes we also see yeast in the urine. The most common type is Candida, and its presence doesn't always mean infection. It could simply be contamination, especially in female patients where yeast from the skin or vaginal tract enters the sample. In patients with urinary catheters, yeast can also represent colonization of the catheter, not necessarily an active infection. But in certain situations like diabetes, immunosuppression, or recent antibiotic use, yeast in the urine can signal a true Candida urinary tract infection. Lastly, let's wrap up with a few other urine tests you might order beyond the standard dipstick and microscopy. First, we have urine osmolality and urine sodium. These help evaluate volume status and renal function. Urine culture is essential when you suspect a UTI. It tells you exactly what organism is growing and which antibiotics it's sensitive to. We also have pregnancy testing done by detecting HCG in urine. Then there are specialized urine hormone tests. A 24-hour urine-free cortisol test is used to screen for Cushing's syndrome, which causes cortisol overproduction. And for suspected pheochromocytoma, you can check urine metanephrines, VMA, or catecholamines. These help detect tumors that secrete excess adrenaline-related hormones. And that wraps up our overview on urinalysis, from the gross examination to the urine dipstick, microscopic sediments, and other lab tests. Thanks for watching, and I'll see you in the next one.